Hello everyone, this is Sarah Sinno and welcome to the second lecture in this series of gastrointestinal pathology. In the first lecture, we have discussed the various pathologic processes affecting the esophagus. In this lecture, we will focus on the stomach. The learning outcomes for this lecture are that you should be able to list some of the common congenital disorders of the stomach. You should be able to distinguish the different types of gastritis and understand the pathophysiology underlying them and the mechanism leading to peptic ulcer disease. You should be able to list the common hypertrophic gastropathies and recognize the common gastric polyps and tumors affecting the stomach, and to be able to explain the pathogenesis underlying the gastric tumors. In order to achieve these learning outcomes, this is the outline that we will follow. We will start first by reviewing the histology of the normal stomach, and then we will go to the congenital disorders and then inflammatory conditions, including acute gastritis, chronic gastritis, their complications, and then we will briefly go over the hypertrophic gastropathies and finally the gastric polyps and tumors. The stomach is a saccular organ with a volume of 1.2 to 1.5 liters. Anatomically, it is divided into five main regions: the cardia, the fundus, the body or corpus, the antrum, and the pylorus. Histologically, the gastric wall consists of the innermost layer, which is the mucosa. Underneath it, there is the submucosa, followed by the muscularis propria, and the outermost layer is the serosa. The mucosa contains several glandular cells, and these cells include the mucus cells, which secrete bicarbonate-rich mucus, parietal cells, which secrete gastric acid and intrinsic factor, chief cells secrete pepsinogen, G cells secrete gastrin, and enterochromaffin-like cells, which secrete histamine. This slide reviews the anatomic zones of the stomach. As we said that the stomach is divided into five anatomic regions, and here we have the cardia, which is located immediately distal to the gastroesophageal junction, and then there's the fundus, which is the dome-shaped portion of the proximal stomach that extends superolateral to the gastroesophageal junction. And then there is the body or corpus, and it comprises the remainder of the stomach, proximal to the incisura. And then the stomach distal to the incisura is called the antrum. And then there is the pylorus. In this slide, we can see the gross appearance of an opened stomach. So this is how a normal stomach looks like. We can see it has gastric folds, also known as rugae. And here we have the esophagus, esophageal mucosa. We can see it is a white, smooth surface, unlike the gastric mucosa, which has the folds. And here the stomach empties into the duodenum. This is a picture from the gastric mucosa taken from the fundus or body. So the fundus or body, you would see the parietal cells and chief cells. So here we can see the parietal cells. They have abundant pink cytoplasm. And below them, we can see the chief cells. They are rather more darker relatively compared to the parietal cells. This is a picture from the gastric wall taken from the antrum. So the antrum, as opposed to the fundus and body, we do not see the parietal cells. Instead, we can see that there are mucus cells because they secrete mucus. Now we will move on to discuss the main congenital disorders of the stomach. We will discuss congenital diaphragmatic hernia and pyloric stenosis. In congenital diaphragmatic hernia, there is a defect or a hole in the diaphragm, and this will allow the abdominal viscera to herniate into the chest. So it's a developmental discontinuity of the diaphragm. And the main complication, one of the complications is lung hypoplasia. Congenital diaphragmatic hernia is different from hiatal hernia, which we discussed in the lecture about the esophagus. In hiatal hernia, only a small portion of the stomach herniates upwards, whereas in congenital diaphragmatic hernia, it is more dramatic. A whole organ or even more than one abdominal organ can herniate upwards into the thorax, causing pulmonary hypoplasia. Pyloric stenosis is a congenital disorder affecting the stomach. It is characterized by concentric enlargement of the pyloric sphincter. It affects boys 3 to 4 times more often than girls, and it is more common in firstborn males. It is seen early in life, where infants present with projectile non-bilious vomiting at 3 to 6 weeks of age. The vomiting is non-bilious because the obstruction is at the level of the stomach, before the duodenum. So the vomitus does not contain bile. Pyloric stenosis is the most common cause of gastric outlet obstruction in infants, and it may appear as a palpable olive-shaped epigastric mass clinically. This is a picture of a stomach, previously open stomach, and here we can notice that the pylorus, there is hypertrophy of the muscle at the gastric outlet. So the muscle hypertrophy may be so prominent that it may appear as a palpable mass. So this is pyloric stenosis. Now we will move on to gastritis or inflammation of the stomach, and we will discuss the different types of gastritis. This slide illustrates the mechanisms underlying gastric injury. Under normal conditions, there is a balance between the damaging factors to the gastric mucosa and protective factors. Examples of damaging factors include gastric acidity, peptic enzymes. Examples of protective factors include mucus secretion, bicarbonate secretion, epithelial regenerative capacity, prostaglandins. When the damaging forces overwhelm the protective factors, such as when there is increase in the damaging factors or decrease in the protective factors, gastric injury occurs. Examples of causes of increase in the damaging factors include H. pylori, NSAIDs, tobacco, alcohol, duodenal gastric reflux. Examples of causes of impaired defense mechanisms include ischemia, shock, and NSAIDs. So when gastric injury occurs due to the damaging forces being overwhelming the protective factors, gastritis occurs. And gastritis can be an acute event or it can be chronic. And gastritis can lead to ulcer. An ulcer is a breach in the mucosa which extends into the submucosa or deeper. And ulcer can occur with acute gastritis or with chronic gastritis. Causes of acute gastritis include excessive alcohol consumption, non-steroidal anti-inflammatory drug use, aspirin use, smoking, heavy smoking, radiation therapy, chemotherapy, etc. Morphologically, there will be acute inflammation, which is represented by the presence of neutrophils. As injury progresses, erosions occur. Erosions, we mean by erosions superficial mucosal defects that are accompanied by neutrophilic infiltrates. This slide shows a stomach with acute gastritis. Note that the gastric mucosa is diffusely hyperemic or erythematous. So as we said, in acute gastritis, we would see acute inflammation as represented by the presence of neutrophils. So here we can see neutrophils present within the gastric glands. So there is a difference between erosions and ulcers. In erosion, there is loss of the superficial epithelium, leading to a defect in the mucosa, and the defect is limited to the mucosa. Ulcers, on the other hand, are deeper. They can extend into the submucosa or muscular layer. Ulcers can arise as a result of an acute injury or as a result of chronic injury. Acutely developing gastric mucosal defects are a well-known complication of NSAIDs. In addition, acute gastric ulceration can occur due to stress-related gastric mucosal injury. Examples of stress-related gastric mucosal injury are shock, sepsis, or severe trauma, which lead to stress ulcers. Curling ulcers are caused by severe burns or trauma. Cushing ulcers are caused by brain injury, and these carry a high risk of perforation. The pathogenesis of stress-related gastric mucosal injury is most often related to local ischemia. So this can be due to systemic hypotension or due to reduced blood flow caused by stress-induced vasoconstriction. This is a picture of a sharply demarcated acute gastric ulcer with surrounding hyperemia. So this ulcer is probably benign. However, all gastric ulcers should be biopsied to rule out malignancy. Ulcers can be complicated by hemorrhage, perforation, and stricture formation due to scarring. Now we will talk about chronic gastritis. Chronic gastritis refers to chronic inflammation in the stomach, eventually leading to intestinal metaplasia and mucosal atrophy. There are two main types of chronic gastritis: H. pylori gastritis and autoimmune gastritis. Peptic ulcer disease is a complication of chronic gastritis. Helicobacter pylori gastritis is the most common form of chronic gastritis. It occurs due to the infection with H. pylori bacteria. Morphologically, it is characterized by the presence of chronic inflammation within the mucosa. So within the mucosa, we will see lymphocytes, plasma cells, lymphoid aggregates. In addition, usually there is active inflammation. And activity, we mean by it the presence of neutrophils. So then neutrophils indicate the activity of inflammation. So in H. pylori gastritis, usually we have chronic active gastritis. And H. pylori gastritis usually starts with the antrum. So as we said, H. pylori gastritis starts in the antrum. However, when the inflammation is prolonged, the gastritis may progress to involve the gastric body and fundus as well. And as we discussed in the beginning of this lecture, the gastric body and fundus contain parietal cells, which secrete gastric acid. So when the inflammation extends into the gastric body and fundus, and when this inflammation is prolonged, this can lead to a decrease in the number of parietal cells, and this will lead to atrophy, gastric atrophy, and also intestinal metaplasia can result. In atrophy, so you have less parietal cells, so you have less acid secretion, so there is hypochloridria, because there is decrease in the number of parietal cells, and this will lead to hypergastrinemia. In addition, with long-standing inflammation, especially when atrophy and intestinal metaplasia develop, there is increased risk of developing gastric dysplasia and gastric adenocarcinoma. Also, there is increased risk of developing extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue, also known as MALT lymphoma, which we will discuss later in this lecture. So a few words about H. pylori. They are curvilinear gram-negative rods. They have flagella, which allow the bacteria to be motile in viscous mucus. They produce urease, which converts endogenous urea to ammonia and bicarbonate, thereby elevating the local gastric pH and enhancing bacterial survival. The H. pylori surrounds itself with a bicarbonate cloud to counter gastric acidity. They can produce toxins, and virulence is strain dependent. Bacteria, for example, with the cytotoxin associated gene A, cause more damage than bacteria that do not have this gene. This slide shows an example of chronic gastritis, where we have the gastric mucosa, and here we can see there are numerous inflammatory cells, chronic inflammatory cells, which are lymphocytes and plasma cells that are present within the lamina propria. The H. pylori organisms can be seen under the microscope. For example, here we can see the H. pylori bacteria in a person with H. pylori gastritis, and we can see that they are curvilinear rods. Here also we can see the curvilinear rods. H. pylori are typically found in the antrum, but they can be seen, as we said, in the body in more advanced disease. Now we will talk about the second type of chronic gastritis, which is autoimmune gastritis. Autoimmune gastritis is much less common than H. pylori gastritis. It accounts for less than 10% of cases of chronic gastritis. It is an autoimmune disease where the patient has autoantibodies targeted against the parietal cells, and in particular, they are targeted against the proton potassium ATPase pump or the proton pump. And the antibodies also are directed against intrinsic factor. Since the antibodies are targeted against the parietal cells, we can imagine that autoimmune gastritis affects the body and fundus and spares the antrum, because in the antrum usually there are no parietal cells. This is in contrast to H. pylori gastritis, which starts with the antrum and then progresses to the body. Autoimmune gastritis is associated with other autoimmune diseases, such as Hashimoto thyroiditis, type 1 diabetes, Graves' disease, etc. So, as we said, autoimmune gastritis is characterized by the presence of autoantibodies that are directed against the parietal cells and intrinsic factor. This will lead to loss of parietal cells, which normally secrete gastric acid and intrinsic factor. The loss of parietal cells causes absence of acid production, or achloridria, and this will stimulate gastrin release, resulting in hypergastrinemia and hyperplasia of the antral gastrin-producing G cells. Intrinsic factor loss results in defective ileal vitamin B12 absorption, and this will lead to vitamin B12 deficiency and pernicious anemia. Pernicious anemia is a form of megaloblastic anemia. Megaloblastic anemia is a macrocytic anemia. The loss of parietal cells in autoimmune gastritis leads to gastric atrophy and intestinal metaplasia, and this causes an increased risk of developing gastric adenocarcinoma. This is a picture that I showed you in the beginning of this lecture of the normal body or fundus of the stomach. Note the abundance of the parietal cells that are present. By comparison, if we look at this picture from a patient with autoimmune gastritis, we do not see the parietal cells that we saw in the normal stomach. So there is loss of parietal cells. So there is gastric atrophy. And this is more evidenced by the thinning of the fundic mucosa. In addition to the atrophy, patients with autoimmune gastritis have chronic inflammatory infiltrate, which is composed of lymphocytes and plasma cells, which we see over here and over here. Those blue cells within the lamina propria are the chronic inflammatory infiltrate which characterize chronic gastritis. This is a picture taken from the gastric mucosa of a patient with autoimmune gastritis. As we can see, there are goblet cells. And goblet cells, as you remember from the esophageal lecture, when we see goblet cells, this means we have intestinal metaplasia. And intestinal metaplasia in the stomach, it occurs as a complication of chronic gastritis. It can occur after H. pylori gastritis, and it is common in autoimmune gastritis, as we see in this case. Note here we have the lymphoplasmacytic chronic inflammatory infiltrate within the lamina propria. Now we will discuss peptic ulcer disease, which is a complication of chronic gastritis. An ulcer, as we discussed earlier, refers to a breach in the mucosa that extends deeply into the submucosa or even deeper. Peptic ulcer disease refers to chronic mucosal ulceration, as opposed to acute ulceration, which we discussed earlier in the lecture. Peptic ulcer disease results from imbalances between defense mechanisms or protective factors and damaging factors that cause chronic gastritis. So the patients usually have chronic gastritis, and the cause mostly is H. pylori infection. Other causes include NSAIDs, cigarette smoking. But the most common cause is H. pylori infection, and the most common location for a peptic ulcer is the proximal duodenum. Another location for a peptic ulcer is the gastric antrum. So within the duodenum, it occurs within the proximal duodenum, and within the stomach, it occurs within the antrum. So how does H. pylori infection cause peptic ulcer disease? Chronic H. pylori-induced antral gastritis causes peptic ulcer disease because it is associated with increased gastric acid secretion and decreased duodenal bicarbonate secretion, thereby leading to the imbalance between the damaging factors and protective factors, leading to a peptic ulcer disease. And as we said, the most common location is the proximal duodenum or gastric antrum. Complications of peptic ulcer disease include bleeding, which is the most common complication, occurring in 15 to 20% of cases. It can lead to perforation and obstruction. This is a picture of a sharply delimited chronic peptic ulcer. Note that the ulcer bed is covered by fibrinopurulent exudate. Peptic ulcers are solitary in more than 80% of cases, and they form a round to oval, sharply punched out defect. The mucosal margin is usually at the same level with the surrounding mucosa. In contrast, ulcers with elevated margins are more characteristic of cancers. Ulcers in the duodenum are generally benign and are associated with H. pylori infection. Gastric ulcers, on the other hand, must be biopsied to rule out malignancy. Now we will briefly discuss hypertrophic gastropathies. We will talk about menetrier disease and Zollinger-Ellison syndrome. In hypertrophic gastropathies, there is epithelial hyperplasia. There is no associated inflammation. Due to the epithelial hyperplasia, the rugae are hypertrophied and look like brain gyri. Hypertrophic gastropathies are rare diseases. An example of a hypertrophic gastropathy is menetrier disease. In menetrier disease, there is diffuse hyperplasia of the foveolar epithelium. Foveolar cells are surface mucus cells or mucus-producing cells. And the hyperplasia of the foveolar epithelium occurs within the body and fundus. It spares the antrum. It is due to excessive secretion of transforming growth factor alpha or TGF alpha. Symptoms include hypoproteinemia, weight loss, diarrhea, and peripheral edema, which is due to protein loss. In adults, there is increased risk of developing gastric adenocarcinoma. In this picture, we can see there is marked hypertrophy of the rugal folds. In this picture, we can see that there is hyperplasia of the foveolar mucus cells. The thickness of the epithelial layer is increased. The glands are elongated. Also, there is parietal cell atrophy. Zollinger-Ellison syndrome is caused by a gastrinoma. A gastrinoma is a gastrin-secreting neuroendocrine tumor. So it's a neuroendocrine tumor that produces gastrin. So there will be very high levels of gastrin. Gastrinomas are located usually within the small intestine or pancreas. Gastrin causes growth of the gastric mucosa and increases gastric acid secretion. So this will result in massive parietal cell hyperplasia and also will result in acid secretion. So patients will present with duodenal ulcers and chronic diarrhea. Gastrinomas are associated with MEN1 syndrome. Now we will discuss the most common gastric polyps, and these include hyperplastic polyps, fungal gland polyps, and gastric adenomas. Then we will talk about the most common malignant tumors affecting the stomach, and these include adenocarcinomas and lymphomas. Neuroendocrine tumors can affect the stomach, as well as gastrointestinal stromal tumor. However, they will not be discussed in this lecture. They will be discussed in the lecture about colonic tumors. Hyperplastic polyps are also called inflammatory polyps. They can occur anywhere in the stomach, but are most commonly found in the antrum. They occur in a background of chronic gastritis usually. This is a picture of a hyperplastic polyp. We can see that the foveolar epithelium is hyperplastic and it's also elongated and tortuous with cystic changes. Fungal gland polyps, as the name implies, they occur in the gastric body and fundus. In the vast majority of cases, they are sporadic and they are associated with use of proton pump inhibitor therapy. Much less commonly, they can occur in individuals with germline mutations in the APC gene, which causes familial adenomatous polyposis. In patients with FAP, so patients with FAP have an increased risk of getting fungal gland polyps. And in those fungal gland polyps, dysplasia can occur in them, and rare cancers have been reported. In contrast, sporadic fungal gland polyps, which are much more common, do not carry a significant risk of neoplasia. Microscopically, fungal gland polyps are characterized by the presence of irregular, dilated fungal glands, as we see in this picture. Gastric adenomas. All gastric adenomas by definition exhibit dysplasia, and the dysplasia can be either low-grade or high-grade. Gastric adenomas usually develop in a background of chronic gastritis with associated atrophy and intestinal metaplasia. Gastric adenomas have a higher risk of developing into carcinoma than colonic adenomas. Therefore, they must be managed more aggressively, and the risk of developing a gastric adenocarcinoma within a gastric adenoma correlates with size. So the larger the adenoma, especially if it's more than 2 centimeters, the risk of developing adenocarcinoma within it is much higher. These are two pictures that show a gastric adenoma. A gastric adenoma is characterized by dysplasia, and this dysplasia can be low grade and high grade. So when there is dysplasia, the, the gastric mucosa appears darker, as we can see. And this is due to the presence of nuclear hyperchromasia and nuclear elongation and pseudostratification of the nuclei, in addition to nuclear enlargement. Now we will discuss the gastric malignant tumors, and we will start with gastric adenocarcinomas. Gastric adenocarcinoma is the most common malignant tumor of the stomach. It comprises more than 90% of all gastric cancers. The incidence varies markedly with geography. For example, in Japan, Chile, Costa Rica, and Eastern Europe, the incidence is 20-fold higher than in other countries like North America, Northern Europe, Africa, Southeast Asia. Gastric adenocarcinoma is often discovered at an advanced stage. Stage is the most important prognostic factor, and it is characterized by the T, N, and M. The T is determined by the depth of invasion, the N is determined by the presence or absence of lymph node metastasis, and the M is determined by the presence or absence of distant metastasis. This slide illustrates some of the risk factors of gastric adenocarcinoma, and these include H. pylori infection, EBV infection, tobacco, rubber, diets rich in salt, such as dried and salted fish and meats, and soy sauce, smoked food, pickled foods, and these lead to the formation of specific N-nitroso compounds. There are two main types of gastric adenocarcinomas. In the first type, it's the intestinal type. Grossly, usually it forms an elevated mass with elevated borders and central ulceration. Microscopically, it is usually composed of invasive atypical glandular structures that invade the gastric wall. The second type of gastric adenocarcinoma is the diffuse type. The diffuse type usually does not form a well-formed exophytic mass. However, it grows within the wall of the stomach. It infiltrates the wall of the stomach, and it will cause diffuse rugal flattening. So the rugae will be flattened, and the wall of the stomach will be rigid and thickened, and this will impart a leather bottle appearance termed linitis plastica. Microscopically, unlike the intestinal type, in the diffuse type, the cancerous cells do not form glands. However, they infiltrate as single cells within the wall of the stomach. The cells have a large mucin vacuole that expands the cytoplasm and pushes the nucleus to the periphery, and this will create a signet ring cell morphology. So the cells are often termed as signet ring cells. Ecadherin loss is a key step in the development of diffuse gastric cancer. This is an example of a gastric adenocarcinoma intestinal type. As you can see, there is a large polypoid bulky mass. In this example of a gastric adenocarcinoma, the cancer is not forming a mass. However, it is forming a large ulcer with elevated borders. So gastric adenocarcinomas can have a variety of gross appearances. This is an example of an intestinal type gastric adenocarcinoma, and as we can see, it is composed of invasive glandular structures that are lined by atypical cells. In this picture, we can see here in the right of the picture invasive adenocarcinoma, intestinal type, and we can see over here that there is intestinal metaplasia, characterized by the presence of goblet cells. Intestinal metaplasia is a precursor lesion to developing intestinal type gastric carcinomas. This is how a gastric adenocarcinoma diffuse type looks like. The gastric wall is markedly thickened, and the rugal folds are partially lost. So this is due to the diffuse infiltration of the tumor cells. So the stomach will have a shrunken leather bottle appearance, also termed as lenitus plastica. The tumor cells in the diffuse type gastric adenocarcinoma have a signet ring appearance. They will infiltrate the gastric wall singly, they do not form glands, and they are characterized by having an intracytoplasmic mucin droplet that pushes the nucleus to the periphery, which will be eccentric and flattened, and this will create a signet ring appearance that is characteristic of these tumors. This slide illustrates the pathogenesis of gastric adenocarcinoma intestinal type. H. pylori infection is thought to be responsible for most of gastric adenocarcinomas. In fact, infection with the cytotoxin-associated gene A, H. pylori strain is the strongest risk factor for the development of gastric adenocarcinoma. Upon infection with this strain of H. pylori, the person develops chronic gastritis, and this can progress into multifocal atrophic gastritis, which can lead to intestinal metaplasia, and then dysplasia, and then carcinoma. Alternatively, the person may develop a duodenal ulcer or a peptic ulcer disease. Usually, patients with atrophy, usually they do not develop an ulcer because people with atrophy, they have a decrease in the number of parietal cells, and parietal cells secrete gastric acid. So with atrophy, there is less parietal cells, so there is less acid. So the patients usually do not develop ulcer. So the persons with ulcer, usually they do not have atrophy. Early gastric cancer refers to gastric carcinoma that was discovered at an early stage, before invasion into the muscularis propria could occur. So the carcinoma is limited to the mucosa or submucosa. And this early gastric carcinoma is common in countries that have high prevalence of gastric carcinomas, such as Japan, where screening programs are conducted to detect early gastric cancer. So there is more liberal use of upper GI endoscopies, thereby facilitating the detection of early gastric cancer. It carries an excellent prognosis because the cancer was discovered at an early stage. Hereditary diffuse gastric cancer is an autosomal dominant cancer susceptibility syndrome where patients are at increased risk of developing diffuse type gastric cancer and invasive lobular breast carcinoma. In hereditary diffuse gastric cancer, the patients have germline loss of function mutations in the tumor suppressor gene CDH1, which encodes ecadherin. Ecadherin is a cell adhesion protein. So mutations in ecadherin lead to loss of cell adhesion, thereby increasing cell motility and therefore increase susceptibility to develop diffuse type gastric cancer and invasive lobular breast carcinoma. So after discussing gastric adenocarcinomas, we now proceed to the second most common type of malignant tumors in the stomach, and this is lymphoma. Extranodal lymphoma refers to a lymphoma occurring outside the lymph nodes. The stomach is the most common site of extranodal lymphoma. Nearly 5% of all gastric malignancies are primary lymphomas of the stomach. And in the stomach, the most common type of lymphoma is the extranodal marginal zone B-cell lymphoma of mucosa-associated lymphoid tissue, also referred to as malt lymphoma. However, other types of lymphomas can also occur in the stomach, and these can include diffuse large B-cell lymphoma, follicular lymphoma, T-cell lymphoma, but they are much less common than the malt lymphoma. Malt lymphoma is a lymphoma of the marginal zone B lymphocytes. The mucosa-associated lymphoid tissue is usually not present in the normal stomach. However, it can be induced as a result of chronic gastritis. H. pylori infection is the most common inducer of gastric malt, and therefore is found in association with most gastric malt lymphomas. So H. pylori infection invokes lymphoid infiltrates, and this leads to the formation of acquired malt. The B lymphocytes actively proliferate and may occasionally undergo neoplastic transformation due to acquisition of genetic abnormalities. The first-line treatment is treating the H. pylori with antibiotics, PPI. So gastric malt lymphoma is a good example where antibacterial therapy is effective in treating a neoplastic condition. Three translocations are associated with gastric malt lymphomas. The most common translocation is translocation 1118. The others include translocation 114, translocation 1418. And these translocations lead to the constitutive activation of NF-kappa B, which is a transcription factor that promotes B cell growth and survival. Most cases of malt lymphomas are responsive to H. pylori eradication. However, there are certain scenarios where the malt lymphoma is not responsive to H. pylori eradication, and these include if specific mutations are detected, such as if these translocations are present, if the lymphoma is deeply infiltrating the gastric wall, and if the lymphoma has transformed to a high-grade lymphoma, such as diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma is more aggressive than malt lymphoma, and if present, the patient must be treated with chemotherapy. These are microscopic images of gastric malt lymphoma. The picture on the left, we can see the diffuse population of lymphoid cells infiltrating the gastric mucosa and submucosa. In the picture on the right is a higher power view where we can see the neoplastic population of lymphoid cells. And here we can see a lymphoepithelial lesion where we can see the lymphocytes surrounding and infiltrating the gastric glands. And this is referred to as lymphoepithelial lesion, which is commonly seen in gastric malt lymphomas. This is a picture of a diffuse large B-cell lymphoma forming a large ulcerated mass. Just by looking at this picture, you cannot tell if this mass corresponds to adenocarcinoma or a diffuse large B-cell lymphoma grossly. You need to examine it under the microscope to be able to know what type of gastric tumor this is. Microscopically, diffuse large B-cell lymphoma is composed of large atypical lymphoid cells. The prognosis of diffuse large B-cell lymphoma depends on the stage at presentation and on other factors. However, the overall 5-year disease-free survival rate is much better than gastric carcinoma. In this lecture, we discussed the different pathologies affecting the stomach, and these pathologies range from non-neoplastic conditions to neoplastic conditions. We first started by discussing the congenital disorders affecting the stomach, and we mentioned that pyloric stenosis is the most common congenital disorder of the stomach. Then we moved to inflammatory conditions, where we talked briefly about acute gastritis and then chronic gastritis, and we mentioned that H. pylori infection is by far the most common cause of chronic gastritis. And we mentioned the different complications that can arise as a result of H. pylori infection, and these complications include gastric ulcer disease. We talked briefly about polyps, hyperplastic polyps, fundal gland polyps, and gastric adenomas. Gastric adenomas are very uncommon polyps. However, they are dysplastic and therefore they carry increased risk of developing gastric adenocarcinoma. And finally, we discussed the malignancies affecting the stomach. Gastric adenocarcinoma is the most common malignancy affecting the stomach, followed by gastric lymphoma, and gastric multilymphoma is the most common type of lymphoma affecting the stomach. In the next lectures, we will move on to the small and large intestines.